Good morning and welcome to the Overview and Scrutiny Management Overview and Scrutiny Management Committee, the West Yorkshire Joint Health Overview and Scrutiny Committee. When I make sure I'm in the right meeting. Good morning, everybody. I wonder if members of the committee would like to introduce themselves. So, Councillor Hutchinson.
Councillor Colin Hutchinson from Culver, Chair.
Thank you, Councillor Addy. You're on mute, Councillor Addy.
Yeah, sorry, I was having some issues with the old messages coming through from that meeting we're just in. Yeah, I'm Councillor Beverly Addy for Combe Valley in Kirklees and member of the panel.
Thank you. Councillor Anderson. No. Councillor Scopes.
Councillor Cataline Anderson.
Oh, thank you.
Good morning.
Thank you. Morning. Thank you. Councillor Scopes.
Hi, Councillor Andrew Scopes, Lead City Council as well. Thank you.
Thank you. Councillor Jamil.
Good morning, everybody. It's Councillor Rizwana Jamil and I'm from Bradford Council.
Thank you. Councillor Coates.
Good morning, everybody. My name's Councillor Alison Coates and I'm also from Bradford.
Councillor Blackburrow.
Good morning, Councillor Blackburrow. I'm the Chair of the Adults Health and Social Care Scrutiny Board at Calderdale Council, and good morning to all.
Councillor Rhodes.
Good morning, everybody. Betty Rhodes, Councillor, Chair of the Wakefield Overview and Scrutiny Health Committee.
Councillor Swift.
Kevin Swift from Wakefield.
Thank you. And do we have Councillor Lee or Councillor Soloway from North Yorkshire here? No. Okay, thank you. We'll put them as apologies if they don't come in. And I'm Councillor Smage from Kirklees. So minutes of the previous meeting. Minutes of the previous meeting have been circulated to everybody. Do we agree that they're a true record? Thank you. Thank you. Are there any items from the minutes that anybody would like to bring up at this point in time? Councillor Scopes.
Yes, thanks, Chair. I thought questions just on the follow-ups on all three of them, just in terms of the major items last time, which I'll just say out loud because we're on a meeting. So the first one is around the review of the services. I think you and the Deputy Chair are going to have conversations about how that is going forward, and I was hoping you could provide an update on that. In terms of the fluidisation, I think just a question about whether you've got a date for more information to come to Scrutiny Board. As I was reminded that I grew up some of my time as a child in Milton Keynes, and I think we had fluoride in the water, and that was good for teeth. And then just on the last one as well, whether how we're going to consider whether there should be more discussion on place-based overview and scrutiny committee. So just some updates, sorry, Chair, but I just need to make sure. I just want to check they're on the agenda going forwards. Thank you.
Yes, thank you. So the West Yorkshire Urgent Care Service Review, I think, which you referred to, it is on our agenda this morning, but we are not taking that item at this meeting. It will come to hopefully the March meeting. In respect to dentistry, we have sent the letter that was agreed that we would send. That has been sent to the government, and we are discussing when the panel can have further information on fluoridisation and how we will do that. I think that will be it. I think we did have some information from the dentistry that we had asked for, yeah, I think that's it. Okay, any other points on the minutes? Right, thank you. We've got deputations or petitions. We've had no notification of any deputations or petitions, Yolande?
None received, Chair.
Thank you, and no public questions.
None received, Chair.
So now we move to harmonisation of commissioning policies. Do we have the officer from the ICB who is leading on this item, please?
Hello, yes, my name's Catherine Thompson. I'm Associate Director of Planned Care for West Yorkshire ICB. I think I was asked to just take questions to save some time on today's agenda, but I'm quite happy to give a brief run through the paper if that would be helpful.
No, the questions will be fine. So do members have questions, Councillor Hutchinson?
Thank you. The evidence-based interventions guidance list 3 that you refer to, you've given a list of a number of those interventions that will now be implemented, but that the original list includes guidance on referral for cataract surgery, specifying the need for shared decision-making between the referring clinician and the patient to try and reduce the number of patients being referred with little or no functional impairment, or patients who, following a discussion about the balance of risks and benefits, may decide that they don't want to go ahead with surgery at that time because it doesn't rule out surgery at a later date if impairment increases. That recommendation hasn't been mentioned in the report, and I just wondered why that was, whether it has been already implemented or whether it's under further discussion, because, you know, cataract surgery is the most commonly performed surgical procedure, and, you know, there is a balance of risk and benefit that patients need to be aware of before they commit to it. And I know from my own practice that was often not actually discussed in sufficient detail. So I just wondered where that sits with the policies of the ICB.
Thank you, Councillor Hutchinson. That's something I'm very happy to speak about. We have already implemented that prior to the publication of the evidence-based interventions. We've been working on our eye care services across the whole of West Yorkshire in primary care optometry and in the hospital eye services for a number of years now. And we looked at the cataract pathway quite early on. We had a bit of a hiatus in the progress of the work over COVID, but we do have that shared decision making as part of our commissioned pathways, and so that is done by our community optometrists prior to referral. More recently, we'd had some success, or quite a bit of success, I think. We'd seen what I would describe as the conversion rate from referral to surgery increase. We don't want it to be 100% because then we might be missing people who would benefit from surgery and who would be willing to have it. But we've seen it steadily increase. And then most recently in December, we implemented something called a single point of access into the electronic referral system that community optometrists now have to send their referrals directly into any hospital eye service, be it an independent sector provider or the NHS. But what the single point of access does is ask the patient to answer a few straightforward questions about, have they had the conversation about whether they want to proceed and understand that they are being referred for surgery? And they need to be able to say yes to that. If they say no, it defaults back so that they get picked up for a conversation through a different route. And then it asks them if there's any challenges with lying down flat and getting breathless, just some high level screening questions that would indicate whether they might need to be seen in an NHS service because they've got more complex health conditions or a complex eye condition as alongside their cataract, or whether they could be seen by any provider, and then they're offered the choice of any appropriate provider within our patch. So that single point of access helps with the reinforcement of that shared decision-making question being asked prior to referral. And early days, as we only implemented that step in December, but it does seem to be working really quite well, and we're not having problems with people saying, no, I haven't had the conversation. So it seems a bit of confirmation that those conversations are happening in primary care optometry.
If I may come back, Chair.
Yeah.
If there's a single point of access, is there also a single form of information that is given to patients when those conversations are occurring? Because an optometrist doesn't do surgery, so they're not really they don't have a close awareness of the risks that there are with cataract surgery, and not everyone ends up better off. And the way those risks are expressed can make a big difference to how people feel about it. And I just wondered whether there was a set of information about that forms part of that conversation.
Thank you, Councillor Hutchinson. Yes, there is.
Can I just, Catherine, just a moment, please. Councillor Hutchinson, I think the echo is when you, that's it. Yes, thank you. Catherine, thank you.
There is a single set of patient information. We developed that really quite early on, and it was available before the single point of access. And when we introduced the shared decision-making pathway, it's available through a number of different routes, and it's not just exclusively for West Yorkshire. We can't mandate that specific information is used over any other information, but it is there, and we ask that all patients are signposted to it as part of the referral for cataract surgery. We have a number of resources developed with a lot of the different voluntary and community sector organisations that are very active in the eye health and eye care world.
Okay, thank you. Just before I bring Councillor Rhodes in, so we had some policies that came to us in summer 2023, yes, and then you've listed in the paragraph below about the evidence-based interventions policies 1 to 7, and that these have been to your transformation committee. So these are already in place, yes, the 1 to 7.
They've been agreed, and we're in the process of implementing them. Number 6 and number 7 are not yet in place, but we need to complete the work to put those in, and we can't mandate implementation until the services are there. What number 6 and 7 require is for additional tests to be done in primary care optometry, and until we have set up a commissioned service so that the optometrists get paid to do those tests, we can't have hospital providers of eye services refusing to accept the patient, because then the patient would have to pay for it themselves, and that wouldn't be right. So we've prepared the business case, we've got the case for change, the financial model and what have you. It's just about identifying the money so we can get those services commissioned, and some of the decision is about whether we only commission services for glaucoma referral, and we probably wouldn't just do diabetic retinopathy, because there's also the test that would be done for that would also be beneficial in age-related macular degeneration, in identifying whether those people would benefit from hospital treatment. And so we'd probably cover those things, but there are more things that we could do to avoid referral to hospitalised services when ongoing treatment wasn't going to be provided. And so our decision really is whether we just do enough to cover these EBIs or whether we can find sufficient money to do more, but money is so constrained we may just go with these ones in the first instance and then grow over future years, because these are the things that'll make the biggest difference to good use of resources.
So these
So
EBIs,
I'm taking that.
Yeah, so these EBI policies are things that you have to do. Yes.
They're guidance, they're not statutory guidance. We don't have to do them, but we are choosing to because they are the right things to do. And I mentioned that I've been working on eye health and eye care services for a number of years. Some of the work that we have been doing in West Yorkshire, somewhat ironically, informed the development of some of these policies. And so it's become a national policy before I've been able to implement the work we've been doing in West Yorkshire ourselves. So it was something we were already wanting to do. We just hadn't quite got there before the policy was published by NHS England.
Okay, thank you. Councillor Rose, do you want to come in? I suspect you're going to ask one of the questions that I would like to ask, but Councillor Rose. Councillor Rose, you're on mute.
Hang on. Okay, I'm off now, hopefully. Can you hear me? Yep.
Yes, yeah.
Okay, thank you for the presentation, but it leaves more questions to answer than information given. Councillor Hutchinson asked the question about information out there. I'd like to know where the information goes out to the public. And from the start of a case of an individual, listening to the plan, the policy and progress or process, I'm at a loss in terms of the patient, because I mean, the patient is still king, not policy. So I've been making some little notes here, Catherine, and we've got a situation in terms of I'm now the patient and I go to my doctor and my doctor says, yes, we need to refer you. You've got cataracts, or the beginning of cataracts, but as we know, you have to have these right before operations will take place. Now, once the doctor's referred me, going back to what you've said, because the view out there is A, capacity, B, I beg your pardon, that's a silly phone, it's been starting all morning. The issue is, have we got the capacity for internal NHS services? And when that person gets to an appointment, can we start off now from the patient king point of view? What's the waiting time for somebody from referral to get to see a specialist in the NHS?
I don't have that waiting information immediately to hand, and it varies between our providers, but I can answer most of that question. So it varies is what I'll say in terms of what happens when the patient is referred, depending on the eye condition. If it is something like cataracts, as you identified, in truth, a GP wouldn't normally look in the eye and say, yes, you've got cataracts, because they wouldn't necessarily have the right equipment in their practice. Most cataracts are identified in the routine eye test, and then the referral would go from primary care optometry. But whatever, it's the same. Once the referral's gone, the referral's gone. We're not stopping it.
Sorry, sorry, Catherine, I'm going to go this thread through needle, because this is something very important for everybody. Because the vision out there at the moment is, if you get a referral, that there is, as you describe, external providers, such as Specsavers and everybody like this, they're actually referring patients for further private intervention. So now I'm going through the NHS route because we need to know that we realise everybody out there is not able to go through the private intervention. We are NHS and this is what we're speaking about. And when we implement policies and procedures and changes, we have a responsibility, and I'm sure you're aware, you have a responsibility actually, in terms of any change and accountability, that there's not a significant change that's not going to be of benefit to the patient. So I'm starting off from that point of view out there. People out there listening into this morning will be very interested in this as a topic. It's high on the list, like dentistry, as you know how it is. So now I'm the patient. I might go to my doctor. I have glasses, so I might go to Specsavers, or I might go to another provider out there, and they'll say, right, yes, we need to refer you. What I want to know is what's the referral time from either the doctor saying you need to go to have see your optician, and you've got your optician, and then whoever it may be, they will refer you. What is the waiting time? Now, I'm adamant that this is part of this conversation. To get to, no, just let me finish. To get to the appointment with a consultant at a hospital, NHS.
For most people, where they have uncomplicated eyes and uncomplicated health conditions, depending on which hospital they choose through the patient choice process, most people are able to access NHS paid for cataract surgery in about 3 weeks.
Is not that dependent again on each hospital through its optical services, that they're actually got the consultant staff in place in making a statement like that? Do you have information? Sorry, do you have information across the patch, across our 5 West Yorkshire districts now, that we do have the capacity for that 3-week appointment? I mean, this is public out there, so public might be expecting a follow-up 3-week appointment average within their own patch.
Can I just come in? I've got a little bit of anecdotal information. So this isn't across West Yorkshire. This is just anecdotal. That I did know. I am aware that Mid Yorkshire have some long waiting times for this. So you can get a choice of going to a hospital setting or another setting, and the other setting is paid for by the NHS. The other setting is a lot quicker than going into a hospital setting. I think, Councillor Rhodes, that's what you are you wanting to know, the hospital setting and the times it's taking?
I'm wanting to know the hospital setting because the time that it's taken when you're given a choice to refer out there is actually where the service has been commissioned out to private providers.
Yes, but it is still paid for by the NHS. And it is the same standard.
I think, Catherine, it would be useful if you just listened for a moment. The issue is, yes, it is privatised out to various companies, but a lot of people are thinking that, and I'm only referring to the information that I've had and the knowledge of somebody who's worked within the optical service for many, many years. The service out there is contracted out to private providers, okay? I know that. I know people that have used it and have been quite satisfied, right? What I'm getting back from some, not all, is the difference between their view of when they go through the NHS itself, if they have the capacity to deliver, and go through the private provider, is a concern in terms of aftercare, etc. That's one of them. Secondly, in the services that are being commissioned out there about referrals and information out to the public, I don't think there is enough information anywhere at the moment, certainly not in opticians, that people can actually pick up any information about the issues like glaucoma or retina detachment, or indeed any eye complaints. So there's a big piece of mystery around it, other than, oh, well, they'll send me to this private provider. They've either been very good outcomes, but I'm hearing that aftercare sometimes is not as good as people would expect through the NHS. That's one part of it. When we're looking at the commissioning in terms of policies, are any of these commissioned private providers supporting the NHS, paid for by the NHS, which is where it's been privatised? Are any of these providers then, through that commissioning and tendering programme, how are they monitored through procurement in terms of delivery of services? Or is that something outside of your scope, Catherine?
Should I answer the bit about the contract monitoring and what have you first?
Please,
so,
Catherine.
All providers of hospital eye services and of cataract surgery specifically have to submit data on the patients about their patient outcomes to something called the National Ophthalmology Database. I stumble because I just call it the NOD data all the time. It's just making sure I get the proper term right. And we do that for sort of the quality of outcome monitoring, checking that sight has been adequately restored, as it were, and that there haven't been complications. We also monitor complication rates across the different providers, and you'll be pleased to know that they are very much comparable and relating to the caseload. So particularly in our hospital eyes, our NHS hospital providers, they get the more complex patients who are more difficult and who might have other things wrong with their eyes as well. And we can expect the outcomes might not be quite the same in terms of sight restoration, because if there's multiple things contributing to the sight loss, there's only so much more to gain. But and you wouldn't see those people having surgery in the private providers.
Okay,
and so there could be a perceived difference. But we do that, and we monitor activity as well.
Yeah, so could you provide to us then the timeframes that people can get appointments across West Yorkshire for the more complex cases, as well as the less complex cases within an NHS setting? Do you know the wait times across West Yorkshire? No, that's what I'm saying.
But I
can you let us have it?
Yes, I can.
Yes. Can you let us have it, please?
That for people with more complex requirements who have to be seen in an NHS hospital trust, their waiting times are longer, because that hospital eye department in the NHS provider has to balance its resources to make sure those people with the most urgent eye care conditions are seen first. And so that might be things requiring surgery such as a detached retina, or people who have suspected glaucoma who need to be seen within 2 weeks, or people who have suspected AMD, again, who need to be seen within 2 weeks. So if you have a stable condition such as a cataract, which, yes, I do appreciate the impact that has on people's lives when their sight is impaired, the outcome of the restoration of their vision, if they wait 3 months longer, will be the same. the outcome of the restoration of vision doesn't deteriorate with an increased weight, whereas for those people with things such as damage to the eye, like a detached retina or glaucoma or AMD, if they are not seen as a matter of urgency, they could have permanent,
Yes, we appreciate
irreversible sight loss.
We appreciate that. Yeah, we appreciate
and the
that.
private providers don't have
yeah,
that balance
no,
to do.
they don't. But if you could give that information
Thank you,
to
Chair.
the committee, that would be great. Councillor
Thank you.
Swift, yeah. Councillor Swift.
Yes, part of my original question, I've actually found the information. I wanted to ask what an EBI was, but I have found that. What I've got now is an add-on really to the query from Betty, which has been referred for further information, and that is that if the waiting information could actually include the separate the subsection is, as it were, of cases that go in the first instance to a kind of quick response privately commissioned organisation, but where they end up back with the NHS. Am I making sense?
Yes, you are. And there are a few cases where that does happen. And that was one of the reasons why we implemented the single point of access, to stop people being referred without necessarily making the choice themselves to a hospital provider that wouldn't be able to undertake their surgery, and then them getting referred onwards from there, which puts an unnecessary delay in their treatment. By using the single point of access, we should be able to almost eliminate that. There will always be people who on sort of initial screening, it looks like they could be seen anywhere, but when the ophthalmologist actually looks at the patient's eye, says, oh, I'm really sorry, we're not going to be able to do this. But just that referral pass through shouldn't happen. It should just be when a person's actually been seen and the surgeon says, no, I'm sorry, I think there's other things that need to be considered. You'll need to be seen in an NHS trust. But I'm not sure if I can get you that data. If I can get you that data for what has been happening, I will, and send it with the waiting time data.
Okay,
thank you.
Thank you. Can I ask a question then around the infertility policy is being reviewed with the Humber and North Yorkshire and South Yorkshire, and it says it's in the early stages. What timeframes have you got for that work? And you also say in your communications and involvement that the proposals for hair removal, wig provision, etc., are subject to a period of public engagement. So what are your timelines for that, please?
So on the IVF policy, the working group across Yorkshire and Humber hasn't even determined its ambition for its end date. I expect it to take about a year. And there will necessarily be engagement as part of that. And we will probably do that together but separately, if that makes sense. We will each lead our own engagement in each of the ICBs, but we'll do it at the same time and in the same way. In terms of the hair removal and wigs, I anticipate we will do a similar approach to the one we took last time, of it being primarily online, but such as with the gluten-free, we contacted people who would be specifically and directly affected now, and we will contact them directly to get their feedback. My timescale for that is to not actually start it until after the May local elections, because I don't want to start before, interrupt, and then close after. And I don't want to rush it to get it it isn't ready to start right now, and I don't want to rush it to get it started and finished before the pre-election period starts. So we've taken a decision to do it properly and thoroughly and be in a position to start as soon as we can after the local elections at the beginning of May.
Okay, thank you. And just to be clear, the policy proposal for wigs excludes the provision of wigs during and after treatment of cancer. So
Yes.
that it is for people who need wigs for because of other health conditions other than cancer. Yes. So the provision of wigs for people with cancer who suffer hair loss will continue to be the same.
As far as I am aware, yes.
Thank you. Councillor Hutchinson.
Thank you, Chair. The referral for the changes to the referrals for bariatric surgery seem to be very sensible and welcome, but on the face of it would open up a huge increase in demand for that surgery, which is quite very resource intensive. So I just wondered whether that had been modelled and any changes in available provision put in place.
Thank you, Councillor Hutchinson. Yes, on one level, yes, it would suggest an increase in demand, and on another level, it doesn't, because the population is the same population. What we're saying is we should prioritise that subgroup of people with the most severe obesity to go straight to surgery or straight for assessment for surgery if it is the right thing for them and they would like to have surgery, because not everybody does, and to prioritise them and not make them go through a 1 or 2 year programme of weight loss in the community, which they may have already tried themselves out with the NHS, and it seems wrong to make them go through it for the sake of ticking a box. This just takes away a tick box, enables them to access treatment sooner. So the capacity is the same, but the patient population is also the same. We're just prioritising really based on health need.
So most of them would have reached that point. It just brings that forward. Okay, so
Yes.
there may be a short-term bulge, so to speak, but that'll work its way through in a couple of years.
Yes.
Thanks.
Thank you, Councillor Coates, and then we'll bring this item to a close. Thank you.
Hi, Catherine. Yes, I've just got a question around the needle biopsy of the prostate. So is this part of like the Ranger tests with in addition to the PSA, and then you'll decide on what the next course of action would be? So is it trying to negate having to have, you know, more intensive surgery at the biopsy stage? I hope that makes sense.
It does. You'll have to excuse me. I'll just have to go back and quickly read what it says, because this isn't one of the ones that's at the front of my mind all of the time. So what this is about is there are different ways of biopsying the prostate when there is suspect cancer. It would never happen instead of a PSA. That PSA would be the first test, and this would happen after referral. And this is about making sure that the test is done in the
3 stages,
least invasive way possible to get the best assessment of the type of cancer and the risk to the patient. And it's about how far the cancer may appear to have progressed at the time of assessment. And it's just about best use of the different tests, and the ones that are more invasive and more complex, saving them for the people whose presentation suggests that they're the ones that need them.
Yeah, I thought that's what it would be. So these are in advance of the MDT making a decision about what treatment path they would be going down.
Yes, this is just part of the diagnostic testing.
Yeah, I thought that was the case. Thank you.
Thank you. Right, so we asked for some more information on the ophthalmology questions, and we'd like timelines for your consultation, please. And also, if you could let us know about the schemes that involve other ICBs as soon as you know those timelines, etc., that would be helpful for us. Okay, thank you very much for that item. Item 8 is the West Yorkshire Urgent Care Service Review update. This item is not going to be considered by the committee today. We will move it hopefully to the March meeting, as there was more information that we needed that was not contained in the report. So we will move on to the non-surgical oncology item. And Jason, are you
Yes,
leading on this? Thank you.
I am, thank you. So just so I can first of all just introduce our colleagues that have joined the call for this item. So firstly, Len Richards.
Yeah, hi, I'm Len Richards. I'm the Chief Exec of Mid Yorkshire Teaching Trust, but I'm also the lead Chief Exec for WIAT, which is the Association of Acute Trusts across West Yorkshire for non-surgical oncology.
Thank you, Len. Saj.
Thank you, Jason, and hello everyone. My name is Saj Azeb. I'm Chief Operating Officer, Deputy Chief Exec at Bradford Teaching Hospital, and the lead Chief Operating Officer for non-surgical oncology.
Thank you, Saj. Angie.
Angie Craig. I am the NSO Programme Director at the West Yorkshire and Harrogate Cancer Alliance. So I'm the one that does all the work when Jason asks me to do.
Yeah, that's a fair summary. And so I'm Jason Pollock. I'm the Programme Director for the West Yorkshire and Harrogate Cancer Alliance. And just to say, kind of the role of the Cancer Alliance is that we are kind of non-statutory organisation set up by NHS England, and we essentially work on delivery of some of the goals set out in the NHS long-term plan for improving cancer survival and outcomes. So when we have scenarios like this, we also try and support our system colleagues to kind of come up with sustainable solutions for how services are delivered. I'm aware that obviously we shared a paper in advance of the meeting, and again we have some really helpful kind of follow-up questions which are always put in the addendum based on comments from Councillor Smage. So what I was planning to do was to give kind of a brief summary of the paper, and then just if that was okay, then just allow the opportunity then for committee members to ask us questions if that was okay. The kind of salient points we wanted to flag up from the paper were is that at this stage the proposals for non-surgical oncology in our view remain under development formally. We've done an awful lot of work in terms of working with clinicians right across the West Yorkshire and Harrogate system in terms of understanding what are the barriers to delivering these services sustainably going forwards, what's on the workforce pressures, what some of the pressures arising from the increasing prevalence of cancer and the increasing demand for care and services. What are the opportunities to innovate? How are services structured elsewhere, and how do West Yorkshire services differ? And what can we learn from those other areas? We've also benefited from an external review of our services, and we've used this kind of through kind of a structured approach set out in the paper around developing a clinical vision, model of care, and options appraisal exercise. An outlined implementation model which has been supported from, as Len said, the West Yorkshire Association of Acute Trust WIAT, the West Yorkshire Integrated Care Board, and indeed from colleagues across the system. And what we've done throughout this process as well is worked on a series of kind of both internal engagement, working with patients throughout. So they've been essentially key to each of our key decision points, working to co-design these services, helping to improve them. And we've also now moved into a further phase of engagement, working with external stakeholders and public, including those who will not be current users of cancer care and services. The point which isn't in the paper, but again I can raise here, is that we have got some interim results actually just yesterday from some of the market research referred to in the paper. Now, these results are interim and they do require further analysis, but again, they do also demonstrate a strong level of public support for some of the thinking and the proposals in the paper. So in particular, there's a support from 82% of local public with respect to the context of potentially travelling to a location whereby specialist care can be provided. And indeed, each of the constituent parts of these proposals seem to have at least plurality support from the public. And indeed, that's also representative both on a geographical basis, and it's representative in terms of their consideration against protected characteristics. And the reason I wanted to make that point is when we last came to speak to you some time ago, there was a request of us to be clear about kind of when we're going to do some engagement and making sure our engagement kind of influenced our thinking, our models, which has been really important to us. So I just want to kind of give a kind of a clear sense about how working with patients and public has influenced our model to this point. A number of key areas. First of all, when we started this conversation off, if I'm honest, it was linked around, for example, where were some of the acute oncology inpatient services being delivered, and exactly how they're being delivered. What we've heard from the public actually is that what's actually most important to them is where outpatient care is being delivered and how chemotherapy service is being provided. So again, we've made sure that actually the fundamental tenets of the programme have actually been reflecting that direction of travel. We've also heard that travel and access is a key concern to patients and public. Again, for those reasons, again, we've also looked at a number of things we can do in terms of access to dispensatory grants, providing more care close to home within the model overall. We've also looked at, for example, what we can do to make sure if patients are asked to go somewhere differently, particularly when they're acutely unwell, how can we do assisted transport, so not a direct impact on the service user. And we've also heard from patients what is a clear thing is about the relationship with primary care, and also about how do we make sure that that people can be informed about these proposals. For those reasons, again, we've done a series of focus groups. We've made sure that a lot of collateral has been provided both in person events and online. We've also done some work with Health Watch, the partner, as well, to make sure, again, we've got that broad-based representative public conversation. And the other thing that we've heard from patients and public as well is it's really important as well that that we are making sure that ultimately that we are thinking not just about the clinical care, but also the care which is provided around the wider needs of a person affected by cancer. So for those reasons, for example, we've been rolling out what's something called holistic needs assessments to make sure that when patients are receiving care, that they're again having their financial needs assessed, their spiritual needs, their physical needs, their other requirements are being reviewed and assessed, and they're being properly supported. We've also made sure the fact is that we're rolling out something called cancer care reviews as well, which involves primary care, and also something called end of treatment summaries as well, which means that when patients complete their non-surgical oncology treatment, particularly if they've had a positive outcome, and again they're not going for further treatment, again we can also help to rehabilitate that person back into their life as it was before they had the cancer diagnosis. So again, all that work's been going on behind the scenes. I know there's going to be a specific question about the point about how does consultation work in this scenario. So again, I wanted to kind of offer a view on that to kind of discuss with members of the committee. And so our kind of view at this stage is that we'll be the ICB Transformation Committee is delegated from the ICB board to be the decision maker with respect to these proposals from an NHS point of view. The ICB Transformation Committee can request or require consultation in scenarios even when it's not legally required. So it will be that committee's decision, not the programme's decision, about whether or not there is actually statutory public consultation in relation to these ideas. Our view is we haven't reached that point yet because we haven't as yet got the opportunity to have the external engagement findings and some work in the sector model described in the paper to demonstrate, how sustainable, how deliverable is the model set out and described. We feel we'll reach that point by the summer. In terms of the point then about how that relates to the regulations relating to this committee, the crux of this comes to whether or not these proposals relate to a substantial variation or change to arrangement of services. Now, the word substantial is not actually defined in the guidance or in law or indeed in the 2024 regulations. We're not sure whether or not, on balance, when you look at the overall improvements to access these proposals, whether or not they would count to be substantial. If they're not substantial, they're not necessarily notifiable. And so it'd be a working with arrangement with the committee formally. However, what I would say is that if there was a strong concern or view or something we could come back to on a later date and you should be really worried about this, we'd really want to work on a constructive and positive basis to make sure is that, again, in reality, we do see quite a strong level of public and clinical support for these proposals. We do need to crack on and deliver, and we do really want to make sure that the public and patient feedback and voice guides us right through. We think that we can demonstrate that how that's been occurring today. We certainly want to make sure it's going forward. So we really want to explore with you any thoughts you have and any further advantage you might feel there might be to statutory public consultation on top of the co-production we've done throughout, and also the engagement work we've done, including representative market research so far. So that would be our kind of initial thought about your question about consultation, but really happy to explore that further. I'll just ask my colleagues if anything they want to say initially further to what I've said before I introduce to questions. Angie, Sajid, or Len? No? Okay.
No, I think
so
you've covered it well. Yeah.
We'll pause it there because I'm conscious you may well have questions for us. I didn't want to take up all the time slots, so if I may pass back over to yourselves.
Thank you. Can I just clarify before we move on to questions?
Yeah.
And I can see the list coming up already for questions.
Yeah.
Can I just clarify that the inpatient services that were at Mid Yorkshire, they moved to Leeds due to staffing requirements, and so there was that just had to move at a particular time. So what you're talking about now is inpatient services going for part of the West Yorkshire area, going to Calderdale, and part being in Leeds still. Yes. So for the north, it would be inpatient services would be in Leeds. For the south part of West Yorkshire, which is confusing in itself, for Calderdale, Kirklees and Wakefield, shall we say, the inpatient services would not go back to Pinderfields, they would go to Calderdale at this moment in time under these proposals. Yes.
So only for one aspect of, I think it's a really important point, and I'll bring Len here as well if it helps. The point is that when we started this off, we had a scenario whereby we essentially had a lack of oncologist cover at Mid Yorkshire Teaching Hospitals Trust. So exactly, we're in an emergency scenario whereby we need to move the care. What we've done is we've actually looked at what range of care can be provided in a local hospital, so essentially in Mid Yorkshire, without the direct oversight of a present medical or clinical oncologist. Because of that, the vast majority of the inpatient care can be delivered in Mid Yorkshire, so it actually results in improvement of where we were. What the paper draws out is that there are a small number of scenarios whereby, basically for safety and efficacy, you have to deliver that care directly overseen by an oncologist. And what these proposals set out is, in that limited scenario, they either split north or south in the way you described Councillor Smedge. But it's just to say that where we are now is a better place than where we were at the starting proposal, because we have actually restored services to Mid Yorkshire. And that means that ultimately the vast majority of patients who, for example, present to an accident emergency overseen by Mid Yorkshire Teaching Hospitals Trust, they will be seen, reviewed and assessed in that place. And that's what we've actually done throughout this proposal. So I'll bring in Angie there to any clarification.
I'm sorry, we can't hear you, Angie.
Can you hear me now?
Yes.
Excellent. So just to add a little bit further clarification, when the patients moved to Leeds, that small proportion of patients who needed that acute inpatient care moved to Leeds, the outpatient service was being provided or supplemented with help and support from Leeds oncologists. Due to a number of stresses and strains on various other bits of the system, that help and support is now being provided by Calderdale medical oncologists. So what we don't want, which is what we've got a little bit of currently, is patients are being looked after in the outpatient setting and the treatment setting by Calderdale consultants, and then going to Leeds for an inpatient care where they know nothing about the patient. They've not been involved in their care, and that doesn't feel right or safe to do that going forward. So that's why the Calderdale inpatient bed base has arisen, to make sure that the people who are looking after the patients day to day are actually looking after them when they become an inpatient if they need that complex care.
Okay, thank you for the clarification. Councillor Scopes.
Yes, thank you very much. I've got a comment and a couple of questions, if that's all right. So the first one is on page 12 of your report, page 66 of the pack, you talk about the impact of locums and it creates uncertainty in staffing levels. I'd just like to highlight it also creates uncertainty or inconsistency in service. So I don't know what your induction process is, but if someone's just coming for the day as a locum, then they're going to have the problems that Angie was just talking about in terms of not knowing the patients. And so the issue with locums and I guess bank staff more generally isn't like their lack of skill. Maybe it's like the lack of, like in a ward, there's dozens of things, you don't know where it is, and you don't know the processes, you don't know the patient. So just wanted to comment that I think that strengthens that point you're making rather than anything else. So that's just a comment, but I think it's really important to recognise the consistency of staff is good. And actually, when we talk to patients about GPs, they say the consistency is something that people really value. And I know people who've used the Leeds services, and where they get a good consultant or team, very much more positive experience. That would be just strengthening that point. I guess just wanted to ask you a little bit about the consultation numbers. So when you say that 80% of the public or majority of the public support this, I guess I'm just trying to understand in my head what you mean. And obviously you're never going to get 100% of the population replying to anything, but I just wanted to get a little bit of sense of that. But I guess my overall opinion is, in terms of your question at the end, yes, I think you need to crack on, definitely, and embed this stuff. I guess I would be reluctant though to not call it significant. So where, if I was a patient, so in Leeds, I guess for us in Leeds, it's not a significant change because we keep going to Leeds. There's no, it's not really. But I guess if I was living somewhere else, I think it's hard. If you're saying your service was going to be here and now it's going to be here, from the patient perspective, I'd say that probably feels significant, but not necessarily for Leeds. So yeah, thanks for that.
Yeah, it's no problem. So I've just a couple points. I think I've seen Len's put in the chat there, agrees with your point, Councillor Scopes, about locums, and again I would also. I think the point we would make as well is that sometimes as well the locums are actually longer term locums as well, so the cost premium to that, delivering that care, is significant. And again, that's the other consideration here. So I think the point about you queried about the numbers. So the way we delivered the kind of numbers for the market research activity is we've actually got a basically field interview of 522 people across West Yorkshire, and the demographically split. The reason we chose that number as an independent piece of work is because you can get to a public sentiment which is significant of overall public view to a few percentage points either way if you basically question the right number of people. So you know, for example, if I was to do market research of 5,000 people, it would probably be just as significant if I was to do it just over 500 people, in terms of, you know, if you ask the right questions, you do so in an open way. We've done it independently of ourselves as well to make sure if there was any kind of sense of, is the NHS speaking to people, we need to give an answer. Indeed, it's all been done independently. That is on top of, I would say as well, the focus group activity, which is done both online and face-to-face. So when you kind of then top those things up, plus consider the patient co-production right through the piece, we think actually we've done quite a bit of work in terms of being able to say, you know, relatively significantly in terms of you know, we kind of have both listened to patient public voice and trying to improve the proposal results, what we hear, which I think is the key thing. It's not just asking people, it's to listen to what you say, isn't it? The other thing I want to say as well is that in terms of the quantum about the impact on people, I think it's fair to say no matter where you live in West Yorkshire, you're more likely to get more care close to home as a result of these proposals overall. I do think we potentially need to do a piece of work to show those impacts and the numbers, because I think some of the concerns about the inpatient side of things are actually relate to a very small number of people week on week. And where they do happen, they're actually being supported by, for example, ambulance-based transport. So, for example, we're not asking the patient themselves to make a journey across West Yorkshire. So I think we need to do some of that work as well to give that assurance. But again, and some of that goes back to your point as well around, you know, how substantial or significant are these proposals considered from a patient's point of view, which I think is really important too. May I, Councillor Spence, may I go to Councillor Hutchinson? I think he's next. Or
Yes, just before you, Councillor Hutchinson. Thanks ever so much.
Sorry, Councillor Smith.
No, it's okay. We've got a problem with an echo. Just when you said about engagement, can you just clarify whether you have engaged with people who would be in Mid Yorkshire who are currently going to Leeds, whether or not the change to Calderdale would be, or would they stay with Leeds? Have you done any engagement in relation to that?
So yes is the example. We've done focus group activities right across West Yorkshire, including in Wakefield and including Dewsbury and Pontefract. That's been both face-to-face and virtual. We've also then done specific market research where we've deliberately gone to demographics by geography to make sure we actually hear those points. And then what we've then done, we've asked people who live in Wakefield essentially that exact question. And what we hear is basically broad support for the proposals on paper. So we were very conscious that it's not just about asking patients, this is about asking the public. So we've made sure that our work in terms of design proposal was led by and working with patients who use the service. This phase of engagement is asking broader public, and we've tried to make sure that public representation is demonstrated by geography, including Wakefield, but also by protected characteristic as well. So we've made sure that the market research responds to those different points.
Okay, Councillor Hutchinson.
Thank you, Chair. Sorry for the echo. I might need to drop out and come back in again. But so several points. One is the report from Professor Sir Mike Richards seems to have been a key foundation on which these recommendations have been based, but it's not been published. We've not been given access to it, which surprises me, given that this was an agenda item that's been planned, and I'm not sure why. My second point is that one of the key drivers for this reconfiguration is the difficulty in recruiting consultant non-surgical oncologists. You make the point that this is one of the few services that doesn't operate on a hub and spoke basis. But you say that the problems with recruitment are factors that affect the whole of the north of England, the Midlands and the southwest of England, who all do hub and spoke. So why do we feel that the West Yorkshire hub and spoke basis is a significant factor when this is a national problem? The key is to develop a sustainable service, and you cannot have a sustainable service unless you factor in a pipeline of training for new consultant non-surgical oncologists. But I can find no mention of any changes to numbers in training programs, removing bottlenecks that exist, that have been undertaken in West Yorkshire, although this was raised at the early, in some detail at the consultations with this committee a couple of 2-3 years ago. Have any changes been put in place to, I would have expected to see a significant part of the paper referring to how you are going to get a sustainability in this process from embedding training within the service, rather than the hope that you might be able to recruit them internationally, which is all that's really referred to. And the third question I have is that Calderdale and Huddersfield seem to be used interchangeably in the report. So in terms of the inpatient beds, are these inpatient beds at Huddersfield Royal Infirmary or at Calderdale Royal Hospital? And if so, are they in place now? Because we know that the Trust has 100% bed occupancy at the moment, which suggests that they're under pressure.
So thank you for those questions, Councillor Hutchinson. So I'll give an initial answer, and I think I'll bring my colleague Angie in to answer some of those as well. So on the point relating to sustainable workforce, there is actually quite a lot of additional work which has gone on behind this as well. I think it's a fair point to say that perhaps some of that's not been drawn out as clear as it could have been in the paper. And again, we're very happy to give any further support on that. The key points to suggest are it's not just about international recruitment. We have actually been working with NHS England regionally and nationally to increase the number of trainees, the number of trainee places being supported through deaneries. Now, those arrangements aren't managed on a West Yorkshire footprint, but we have been doing that. We've also been working as a Cancer Alliance with the National Cancer Programme team as well on supply factors, because as the paper does identify, there is essentially a national shortage here, and the Royal College of Radiologists has indicated without change, the gap could treble over the course of this decade. So again, what we've been doing is we've been actually working with the deaneries to increase supply. We've been looking at the work with the National Cancer Programme team as well to basically increase national supply and national prominence to the issue of non-surgical oncologist recruitment. Again, having some success there. And the third key thing we've been doing as well is we've been looking around exactly within the discipline of oncologists, what part of that has to be done by a medical oncologist, a medically trained person, versus could be done from a consultant level post in either being, for example, a pharmacist or a nurse or another allied health professional. And what we have done both across the north and the south sector is we've implemented a number of consultant pharmacists, a number of nurse consultant and other posts, which have given that rigour and sustainability to both sectors and have actually helped us improve where we were then to where we are now. I agree that some of those points can be further drawn out in the paper, and again, we can bring those forward. I just want to give that assurance, actually, there is quite a lot of work going on behind there. You asked me the question as well about Professor Sir Mike Richards' report. So again, our view on this is was that ultimately the direction of travel we've actually followed as a group has been guided both by Professor Mike Richards and indeed the clinical steering group. Indeed, actually, the direction we've gone has also been guided quite heavily by the patient and public voice. So when you see what we've actually done versus actually how some of Mike's considerations were developed at the time, actually you'll see a difference. And what we wanted to do was to make sure is we brought Mike's report to you with the proposals, including the full engagement report together, so you could see the whole range of clinical evidence that we've used to guide our thinking, as opposed to do so in advance. And our other consideration to that was as well is that we did, and I think I did put this in the addendum, is we did have a request for essentially to have that published in advance as a single item. And we felt actually it was wrong not to give yourselves, the committee, the opportunity to scrutinise that alongside all the rest of the reports and the engagement outcomes before we put it in the public domain. So our sense is that we are very happy to share that. We would like to do it as one whole piece when we've done the engagement outcomes, and you can then see ultimately how our proposals have guided by the range of clinical evidence that we've had overall. The points about the use of the terminology and exact configuration of the Huddersfield bed base, I'll bring in Angie to give you a further elaboration there.
It's definitely Huddersfield where the bed base is, and there's been a piece of work that's been completed by CHFT Trust to expand the bed base on the Huddersfield site, and those beds should be open. Was due in January, but of course with everything else we get a little bit of slippage, don't we? So it should be in March that those beds are actually open, so that those patient flows will happen in the way that we would want to. I just wanted to very quickly go back to the consultant oncologist bit. Yes, we have increased the training places, but they're not filled. So there's 50% of the new training places are not filled. And so we will be looking with the deanery and the Royal Colleges how we perhaps use international recruitment to fill those going forward. The horrible fact is, Councillor Hutchinson, if we map out everybody who's due to retire and move on a kind of what's happened in the past, and if we take every single trainee we've got and we take all the international recruits that we've got, of which we've now only got 2, I think, that are suitable to be appointed, we will be 14 oncologists short by 2027, and that's the scary bit. And that's the bit why that blended workforce of only getting experts to do what experts can through use of consultant advanced practice pharmacist and nursing staff and AHP staff is absolutely the way that we have to move to, because we're just not going to have enough to do all the things that we need to do.
Okay, thank you.
I certainly would welcome it if you would share the information about the training aspect of this, because it really is integral to a good National Health Service to actually grow our own. I accept that there are other disciplines that can play a role, but it has to be founded on a good workforce of consultant non-surgical oncologists.
Yeah, so we'll take that away. And may I bring in Len here, because I think Len might want to just add something further to what Angie said.
Yeah, if I could please. And it was just to reinforce the point that Angie said. I think what we're finding is that our consultant pharmacists, our advanced nurse practitioners, our consultant nurses are developing in this field really quite remarkably and doing a great job here within West Yorkshire. And I think the model for non-surgical oncology going forward, just based on the numbers that Angie said, and recognising that this is a national problem, as you've outlined, Councillor Hutchinson, is that the dominance of the medical consultants as the model of delivery, I think will have to change over the next few years, and we're in the vanguard of that. The other thing that I would say as well is that given the shortages of across the country, it is really important that we adopt a model that is attractive to those trainees, because even though if we had all of the trainees in post, we still will have gaps. It is incumbent on us to provide a service that is attractive so that we do get all of those trainees coming forward. And I guess that's one of the reasons that we've really driven a model that does respond to the issues that in the Mike Richards report, but is also being developed by the clinical forum as well, because it is, we don't want to design a model that nobody wants to work in. Similarly, we don't want to hang on to what we've got now, because clearly there are issues and it is fragile and not sustainable. So we've engaged with clinical staff, medical, pharmacy, nursing, advanced practitioners, to try and build on the principles in the Mike Richards report, but develop something that is attractive for them to work in, because it's got to be attractive if we're going to maintain the services going forward. So I just wanted to add that as support to what Angie and Jason were saying.
Okay, thank you. Councillor Blackborough.
Yeah, thank you, Chair, and thank you, Jason, for the comprehensive report. It was a concern in relation to resources that I was equally going to raise, and I think it's about the retention once we've trained these people. That's the way it's about keeping these people as well, because I think as a smaller authority, we tend to lose them to the bigger areas, Manchester and sort of London and all the different areas. The two different elements, I suppose, and one is about the engagement. It's about engagement to hard to reach people, because actually, and I'm specifically probably going to mention in relation to areas of higher deprivation. How do we engage with those people? Because actually, those are the people that actually are going over the radar, shall we say, when we're not engaging properly or effectively with those people. Equally, I think people have changed their attitude in relation to going out. So we've got quite a number of older people that are no longer going out a great deal. So actually, those are some of the issues. The issue I wanted to just expand on was the financial implications. Because I know it was very brief in terms of what you indicated you'd need additional resources, but that it wasn't. There's no outline as to what those are. So I think those are the most important elements from the report that I can see. But thank you.
Yeah. So thank you for that. So just to pick up those 2 points, I'll bring in Angie again. I think that's really helpful just to kind of outline. So I would absolutely agree that kind of engagement with hard to reach communities is exceptionally important, because again, when you do engagement, sometimes there's a risk you always hear to people who are naturally engaged, naturally people come forward. So we have done quite a lot of work here to make sure the fact is that we do deliberately go out and reach. So for example, what we have done is we have looked at our engagement methods by socioeconomic decile, to make sure, again, we're considering health inequalities with respect to that. We also have mapped as well our engagement methods by doing specific sessions and work by protected characteristic group. So we have, for example, within this looked at, for example, from various disability groups. We've also looked at it from the perspective of people who are affected by different age ranges, because again, older people are overrepresenting the use of these particular services. We've also looked at, for example, other protected characteristic groups such as sexual orientation, and we've also, attempted a conversation with other groups whereby there might be a link, for example, the Maternity Voices Partnership. So again, we have looked at it through those lenses too. In terms of financial implications, I think it's fair to say again we are developing essentially an outline business case for the full kind of costs of the model. So there are some savings to be made from the model in terms of, for example, we can reduce local spend successfully in terms of the factors that will result in a net savings to the system, but those savings will need to be reinvested in the additional post infrastructure we have. There are some behind this. There are some parts of the proposal where it's revenue spend, for example, staffing, and there are some parts of the proposal where there's capital expenditure. So there's a reference in the paper to developing an e-prescribing system, which is common for chemotherapy, which will be help around information share. So again, what we will be able to do as well, we haven't actually got that work completed yet, and we do want to make sure we've got financial balance. We have got a lot of support from the White Directors of Finance, and we will be presenting a business case there to make sure that proposals are both sustainable and affordable. What I am pleased to say is that from my own point of view as the Cancer Alliance, we've seen a really strong level of support from all the trusts to say this is absolutely a vital service to patients. Indeed, I've been pleased to see actually that kind of financial barrier not been put in place. I'd finally also agree with you on the point about not losing people to other areas. When we say some of these issues are national, they are, but again, they're not felt the same way in London. Because you have a concentration of cancer centres there. So we do need to make sure we don't lose people. And that's all about role design. It's about taking people with us. It's about, for example, looking at the retention model and looking at training development. And it's also about building relationships. So we come at this as kind of a service for West Yorkshire, as opposed to 6 services operating independently where people can feel a little bit isolated. So again, a lot of that work has been going on behind the scenes to take people with us. I'll bring in Angie there as well to add to that, Emma.
So just to take them in reverse order, as we're already talking about the money, we've got a bit of a timeline to get a business case, first outline business case by October this year. As you'll appreciate, we're working through aspects of the model and trying to cost it up. We'll have a narrative by March and hopefully those costs. At the moment, we've done a bit of baselining and we reckon we're spending about 3 million quid, if you like, in excess of what we need to around the massive use of locums, additional hours that staff are working, agency nursing, etc., etc. So some of that we'll get out. Some of it we won't. It'll be immediately. It'll be a longer term thing around some of the agency nursing. And we're also doing a big bit of capacity and demand work around our chemotherapy units to say, all right, then have we got enough now? Because actually, if we want to provide a bit more chemotherapy closer to home, we need to make sure we've got enough to be able to do that. So we've got to work those few things through. So it's not going to be huge because most of this is about building our infrastructure around our supporting AHP nursing type workforces. And I'll just look at Saj because he knows he's got quite a lot of work to do in Bradford to actually build that underpinning acute oncology workforce. So we know about it. We're just trying to look and see what it looks like and what that costs. But we'll come back and we'll share it in October when we've got that. As hanging on to everybody that we need to. We've hung on to nearly every trainee we've trained in recent times. I don't think we've lost anybody recently. And we do spend a lot of time loving them. We've got a lot of work going on with registrars at the moment because we absolutely recognise that they're our future workforce. So if we don't get them engaged in the model, we're going to have, as Jason said, built something they don't like. So that's really important to us. Our problem is actually retirements or people coming towards the end of their career and wanting to reduce their hours. And that's the thing that's kind of causing us that little bit of, oh, heck, how are we going to deal with that whilst looking after the people that we've got to make sure that we don't push them over the edge. When we did our engagement, we did the first round with Healthwatch and we went out to a lot of areas and we specifically focused on inner city areas. But we had a few issues, if you could say, in the fact that when we got to Bradford, we didn't actually have a single Bradford resident who turned up to the meeting. So we went back and engaged with existing groups around South Asian men, Asian women, Roma populations, learning disabilities, veterans. We've got an event coming up in actually, I think it's the Wakefield patch, might be a bit further out, around an assisted living facility because we recognise that actually the older age group is the bigger one that has cancer. So we're going to do a bit of an event with a care home group around those. So we're trying to cover as many bases as we possibly can and go out to as many folks as we possibly can. And anybody who asks, we go. So I hope that provides some reassurance.
Thank you.
Councillor Rhodes.
Okay, thank you, Chair. There's been a lot of information given out here today in terms of the processes and plans for the future. And as Councillor Hutchinson mentioned, this has been on our agenda for quite some time in terms of the delivery of service, training, staffing, etc., etc. Now, first of all, where and how did you go out to the public to consult? Where did you do it in Wakefield? I'm not on about you getting to groups that are out. I'm on about the public in general. Where did you make any effort to, and I'll say this across all the places, there seems to be a concerted effort to get to the same people, but the public out there are the public in general. So where in Wakefield or in anywhere else did you actually communicate, inform, where the public could actually go to see what the plans were and whatever changes were going to be? Question one. Question two. I'm glad to see that Len's been able to attend the meeting this morning from the Wakefield Mid-Yorkshire Trust. Nice to see you, Len.
Oh, nice to see you, Becky.
Now, the question here is, the councillor from Leeds, quite obviously, Leeds is and has been the major source of areas of service delivery in many aspects of NHS over many years. And of course, we recognise that. But what is going to change from Wakefield's perspective that I'm not aware of? It wasn't identified this morning what that change is going to be. But all I do know from this morning is it's going to be at Calderdale, but maybe it might be at Huddersfield. We don't know. I know your report has addressed issues in terms of travel, etc., and access to travel and arrangements to get to wherever it is. But you need to identify to this committee this morning, I'll go for Wakefield, and if anybody else wants to take it up from their point of view, what are the changes specifically to non-surgical oncology where the people of Wakefield are going to have to travel to get it? That's important. Because as the public out there, you seem to want us to recommend today that we agree with what you're doing. I'm sorry, but I'm going to state in a position now that unless I, on behalf of the Scrutiny Committee of Health for Wakefield, am made aware what these changes are, how they're going to impact, or how are they going to deliver better services, then I'm not agreeing to support this at all this morning. And I think at this stage, it's important that we do know these issues in order to make an informed decision. Secondly, what hasn't been mentioned here this morning is how this is going to add value. And you have a report going to the ICB board this afternoon, which is slight mention in your report, and it's been mentioned already, of how to inform hard to reach groups. What work you're doing there. Now, a comment has been made that not one person turned up to whatever. That actually depends how you relate and communicate with the group in their own area. Because as you know, we have a lot of our groups who live in an area, within a ward, within a district, who are easy to get to. And it's the communication, the type of communication to get to them, that's important. Because we seem to be considering that the only way to do it is go online. Well, some of our groups out there want to have the opportunity of face-to-face and ask the questions, simple questions and comments that the public understand, because we are dealing with the public. And I'm hoping this morning that any of the public listening to this item this morning will actually be able to gain any confidence that what's happening is going to be better. Because, for instance, one of the papers going today that you haven't mentioned here in yours, one of the papers is going to the ICB board in Wakefield today, and I'm going to ask the question in advance of it. How is this going to improve the statistics in relation to cancer care? because I seem to recollect from today's paper, and if I'm wrong, do please forgive me, that we're not even reaching the 75% target. We're well below it. So why hasn't that been part of any of the information given today as to how this is going to improve the overall waiting times for cancer care in general terms? And I have to say, Chair, that in that recommendation that's expected this morning, I am not of the opinion that we have had enough information other than verbal reports here today, without any of them being backed up in further information, that I'm happy about at all. And I think we've got to consider, and I'm going to ask the question, the very last one. Yes, you've said we need to get on and get it done. We don't want to be part of any delayed process as a scrutiny board or as scrutiny at place that will actually delay what is going to be improved performance outcomes, that the public, and I'm not about focus groups now, that the public, through proper communications and intent to communicate, I've not heard of one in terms of Wakefield. You've mentioned Health Watch. Well, they're nearly a statutory organisation. Whereabouts are the public going to get to know the questions I've asked in terms of the issues that will actually improve the situation, the waiting times, the targets, etc., which is what this is all about. This is not all about just a professor or somebody else coming up with a way forward. This is about the public out there believing that what's happening through the Cancer Alliance and your good selves is going to deliver better outcomes for targets and better information as to how the public out there are going to be accommodated with their cancer care. Thank you, Chair.
Okay. So respectfully, we do, you know, I think as a system we strongly disagree with some of the sentiment there, but I will go through all the questions you've raised there. So I think in terms of the point about that we haven't engaged with the public in Wakefield, we would challenge that. So to be precise, we have actually asked 71 people who are from the public from Wakefield. These are not people who are direct users of the services right now. And the way we've engaged those people, we've done in-person market research activities where we canvassed essentially on the street. And what we've done is, in terms of delivering that work independently of ourselves, is presented them with information about the proposals, where we are now. We've asked them a series of open-ended questions in terms of what the priorities are for people. We've asked them about resonance on those proposals in terms of how far they strongly agree or disagree with the proposals on the Likert scale. We've asked examples of questions in terms of their resonance and feedback and comments. And we've also used that feedback then to then design and improve the proposals thereafter. Furthermore, in terms of the work that's been done in Wakefield, in terms of it hasn't been all online. We have done in-person focus groups. There is a comment actually about, you know, Health Watch, but it was Health Watch Wakefield. So we used Health Watch Wakefield to essentially advertise those sessions amongst the community representatives in Wakefield. In terms of the patient and public voice in Wakefield as well, what we've also done is we've also been working through the trust as well to make sure that, again, patients, staff and other representatives are guided to propose this point. In terms of staff perspective and residents in the Wakefield area, we've actually canvassed and actually worked with more than 60 individuals as part of the South sector, including from Wakefield, in terms of how they actually feel and how they actually interact with these proposals. And as I said at the start, we've actually had a patient on the steering group, indeed other patients invest in these proposals right from the very start. So I think it probably doesn't come through as clearly in the paper as it could do. And again, we're very happy to come with a further update because this was really an update as opposed to asking you as a scrutiny committee to formally approve what we've asked to do. But what we would say is that we think that on balance of data in terms of actuals, we think that we can demonstrate that we have gone out to the public in Wakefield. We have listened to the public in Wakefield in the same way we've listened to the public in each of the places. And what the actual data demonstrates is that we do have a level of support for what we're trying to do. In terms of the points about cancer waiting times, those are all very fair points. I think what we have tried to do in the paper and again the addendum is try to demonstrate that when people access these services, it's not in the diagnostic phase of the pathway. So it wouldn't be true to say to the public again that these proposals will directly improve the 75% standard, because they won't do, because this is actually about how we look after people who are diagnosed with cancer. The 75% standard considers people who have been under investigation and consideration for cancer symptoms. What these proposals will do, though, is they will help us deliver compliance against the 31-day treatment standard, which looks at, for example, when we've got a consideration of cancer and we've got a decision to treat, then how do we deliver that through essentially either through radiotherapy, chemotherapy, surgery, or another treatment. We have demonstrated in the paper again that there is some improvement there, and we're doing some work on that, and that is a key objective and goal for the actual project. In terms of the travel points you make, we have done some work which isn't referenced directly in the paper in terms of travel and access analysis. We've looked at, for example, based on where people live, where would they actually attend in different scenarios on this model, and that considers both public transport means and private transport means. We've also looked at from the perspective of both costs and distance. And the key point we wanted to make in terms of what will feel different here to residents of Wakefield is that they are much more likely to, indeed, more will receive outpatient and chemotherapy care in hospitals within Mid Yorkshire Teaching Hospitals Trust in the future than would be the case now. So the key changes are, from the perspective of a Wakefield population, is that you are more likely to receive your chemotherapy in a local hospital or close to home than you are now. You're more likely to receive your outpatient care in your local hospital than you do now. And the change relating to inpatient care has been designed in such a way it relates to a very small number of patients, because we've actually invested in the infrastructure in Mid Yorkshire Teaching Hospitals Trust with another inpatient care in that location. So we feel that if we were able to, to present the facts which are based on the numbers in the way to, people who wait for need or other places, we would feel that that would be given support. Indeed, that support I've referenced is at this stage evidenced through some of the actual independent market research activity we've done. We're quite open to the fact we might need to do some more work. And again, we're very open to the point that, again, that might need to present in the paper and subsequent updates in a different way. But we would challenge the point of view that we haven't tried to listen to public sentiment in Wakefield or give an honest portrayal of these circumstances Councillor Rhodes.
Well, I'm going on the statistics of the amount of people in terms of the communication through Health Watch who are totally unaware, and I'm with the public now, who are totally unaware that there was any such survey going on in Wakefield, in any of the wards across Wakefield, where we are very active. And I'm unaware, and as a chair of Scrutiny, if we aren't aware of what's happening in our own patches through place, then I think it's a very sad indictment. And when I'm looking at the numbers through your survey of the questions that were asked from the commissioner, I have an opinion on, well, it depends who's playing the tune, what you ask the piper to play. But I mean, I'm on about now proper consultation. Secondly, I do think in terms of each place, that the information you've given out, you've concentrated on Wakefield, everybody out there will be looking at what the difference is going to mean in terms of better services, not any kind of centralisation or whatever, and no vagueness about it, because I think that's really important, that people understand what the provision is going to be. And I'm also aware, and I'm sorry, I'm going to, Angie, I'm also aware that the statement has been made in terms of NHS funding for change, that it is challenging for everybody, as we know, including local authorities. And in terms of the challenges that you've outlined for change, which I hope is going to provide better services, Angie mentioned that obviously there's a resource implication, maybe a budget implication. That's not been mentioned in terms of what that gap is, whether it's something for the funding streams for the future you're going to be able to accommodate when we have other boards with huge gaps to actually identify savings, to the point of where they're restructuring or actually looking for voluntary redundancies. And it's all coming out of one big pot. Now, at what point, I mean, I know that there was an answer to the question that it could be 6 months or whatever. At what point within these proposals is there going to be any recognition, if there is going to be a resource implication, what it's going to be, where it's going to be, And is it going to affect services either through a revenue cost or a capital cost, Jason?
So to answer that question directly, the answer to that question, that final question, is October. So what Angie indicated is that the presentation of any revenue and capital cost implications from these proposals will be presented to the Wyatt Director of Finance in October. And the reason why they're not available fully now is because they're being prepared as part of the implementation of the North and South sector model. In terms of the reassurance about, is that going to create the circumstances whereby we can't deliver the model that's been described? The answer to that question is no, because we already have the significant support of, indeed, all the Wyatt chief executives, and there's one here. We have the support of the clinical community in both the North and South sectors described. We have the support, obviously, the Cancer Alliance and NHS England has been described in the paper, and we also have the support as well as around essentially the transitional cost arrangements in each provider trust. What I will say, the cost of delivering this kind of engagement work, this improvement activity as well, we've delivered as a Cancer Alliance. So we've delivered this kind of improvement programme without it kind of impacting on other NHS resources at all. So again, we really have as a system tried to prioritise this work and trying to make sure it does work. I will happily go back to the discussions about, how some of these proposals are advertised amongst the Wakefield community. Because, for example, again, I'm aware, for example, that the Health Watch Wakefield accounts and some of their community engagements were directly engaged in the kinds of focus groups there. One of the reasons why we did actually continue with the market research was because actually we didn't get as fully representative view as we wanted to. So we have done in-person work, we have done social media-based work, because some people do prefer digital means of communication. We've also done in-person market research as well. And again, Angie's given a kind of good presentation of some of the work we've done with particular protected characteristic groups, both on a kind of a system-wide basis and also on a geographical basis. What I would like to say as well is that overall, we are keen to hear more from the public about these proposals. We're very happy to outline exactly how the public voice has impacted on what we've done. We're trying to give some of the examples that in our paper today, but we want to make sure it is clear that that we can demonstrate how we are taking people with us, because what we have heard so far from the people we've generally spoken to, and that's not just from Wakefield, it's from across each of the constituent places, is that we have heard a good level of support, because of what the message the public have seemed to be hearing is, and it's not just questions led by us, by the way, it's questions led by market research. So it's not essentially we ask the questions to get the answers we want.
I know.
But we have asked the questions basically of folks, then say, in terms of presenting what are the real impacts of these proposals around, and how far do you support them on a scale of strongly disagree to agree? What are the other things we haven't asked you which are important to you? What other ideas do you have? And we have very sincerely over this period of time try to improve and rework on all these proposals to make sure we listen to the voice of each of our constituent places. So I just want to reassure you, some of the reason why this has taken a while is because we are really trying to listen. And my only real strong dissonance with what you've said is that we're not really keen to listen, because we are. Our only real point, to be honest with you, is we're not at this stage certain what further value statutory public consultation would add, because ultimately that's a sense of unfiltered consultation. So we wouldn't necessarily be able to, for example, through such an activity, be able to guide a certain number or response rate from Wakefield or another place. So we want to make sure that overall the way we deliver this work is representative and takes people with us, be them staff or others.
Thank you, Jason. I'm going to take 2 points out of your response to me, okay, that I can actually report back, as I do from my meetings, to my own Wakefield Scrutiny Committee. And 2 of those points are, first of all, I asked the question on financial support, financial resources to deal with your proposals. And am I right? I've just been making some notes, Jason, and everybody. Am I right in saying, my understanding is that there isn't going to be a financial impact in delivering for the future on the plans that you've identified, bearing in mind the challenges that there are from NHS England on budgets?
So I'll give you a precise answer to that, and I'll bring in Len and Saj as well, because they may wish to comment further. The cost of delivering care for people who need NSO services will increase in the future. That is unavoidable because more people have cancer. And it's also true to say that more people will have subsequent requirements for chemotherapy and other treatments. So as a product of people living longer and having better care outcomes, you mentioned about clinical, you mentioned about the stage diagnosis, which has improved by about 3 percentage points in West Yorkshire in the last few years. So as a result of those things, more people require more care. They will require that care for longer. And so there will be a resource impact from that, which will be protected, which will be delivered through the tariff scenario. In terms of the direct costs of this particular reconfiguration, what I'm saying is those will be managed within existing NHS systems, and we are not anticipating that, again, there will be a challenge financially to deliver the impact of these proposals from reconfiguration in terms of how we deliver those on the ground. We are absolutely making sure that that we've got full financial support before we take these proposals through the formal governance system, which is exactly what we've been doing through WIATs, through the DOFs, through each individual trust. And it's why we've actually had a financial work stream sit alongside the clinical work stream right from the access proposals. So we would like to offer reassurance on that one now, Councillor Rhodes. May I bring in Saj and Len if I just missed anything there on that point, please?
Can I just come in, Betty? I think the points that Jason makes are accurate and to the point. You know, the future of cancer care services will increase because there'll be more patients, there will be more cancer, we will have to respond to that. But within our current setup, we are spending a lot of money now, and I think Angie identified 3 million more on premium costs to either locums, agency staff, etc., because our system is too fragile, and therefore the requirements of the new reconfiguration will be to make that more resilient and therefore move away from those premium time costs, those overtime costs that have a burden on the individuals as well, not just a financial cost, but have a burden on people who feel committed to the service and therefore have to do the extra shift, etc. So my sense is it will be better value for money going forward, and that's the agreement amongst the chief execs of WIAT, and therefore that's the commitment that we make, that we will meet those costs because it will be better value for money going forward.
It's a given, members of the community, through the chair, that obviously as time moves on, in terms of the population, the demography and the needs of people, that there, unfortunately, I have to say, that there will be and could be an increase in cancer care across our district. That's a given.
Yeah.
My question was, in this reconfiguration that's taken or intended to take place, which executives have given their support to, it's the clinical support that's been given. My concern is, in challenging budgets for the future through the ICB, through the trusts and from NHS England, Len has actually said that you'll be given support in terms of going forward. I'm concerned that that financial support, and the question is, if it's needed for reconfiguration, is going to be available, but not at the risk to other services. Is that something, Len, through your chief executives, that you've been able to identify?
Yeah, so our directors of finance are all over these plans, as are our chief execs. We get feedback from Jason and Angie routinely through WIAT. We believe that the cost envelope of what we're currently spending should be sufficient, but we will spend that money better on a reconfiguration because it will be more resilient going forward than we're currently having to spend it on premium time, sort of urgent requests, that sort of thing. So our view is we're pretty confident that we can go forward with this reconfiguration within the cost envelope that we've got.
And lastly, Chair, I know we've got Sajid wanting to come in. Lastly, is it possible, Chair, we've had a lengthy information trail this morning from our representatives, which I'm very grateful for, and I'm sure we all are. Is it possible, Chair, that in terms of this as a reconfiguration, which it is, that each place, and we're involved here from each place, from our scrutiny, that each place is given information relative to the change that's likely to take place through the reconfiguration in their area, because that's what people from where we are elected from will want to know. And I think that in itself would be extremely useful, because when we have people coming or we have cancer care on our individual agendas for the future, I think it's imperative that we all have that information, that we can actually say in the reconfiguration in your place, X is what the proposal is going to be. And what is that going to deliver in terms of cancer care? And how you've actually looked into the issues behind it in terms of travel, support, intelligence, information, etc. And I think that would be valuable, Chair, if we can have that moving forward, because as you say, Jason, and thank you all for your presentation, as you say, the months are going on and it's going to go on through the year before we actually get, was it October you said, Angie, before we actually get something in October that's going to have a final dot on it, as I like to put it. So I'd like to ask, Chair, if that's a possibility before we bring Sajid in, which each place is going to be part of the information, and we can then say to our own scrutinies, this is what's going to happen, and this is a reconfiguration, but in our place, this is where we're going to be. And I think that's vital. If that's possible, Chair, from our representatives this morning, I think that's going to be to our advantage.
Yes, I would agree. I think that is important, because I think, and I'm conscious that we haven't talked about Bradford area at all.
Yes, yes.
As well.
Yeah.
And I think that because each place is going to be affected differently.
Yes.
To this, and I think that is important. Can I just bring Sajid in, and then Councillor Addy's been waiting for a little while, and then Councillor Coates for the Bradford perspective, and then I'll bring Councillor Swift in. Thank you.
Thank you, Councillor Smith, and thank you, Councillor Rhodes. It was just your last point, actually. I think that's a really valid point, and I think that will give you the level of granularity that people would want to see in terms of what does this mean for our individual place. But there was just a couple of things I wanted to pull out from what Jason had highlighted around what this change means, and what Angie had highlighted in a response to an earlier question. And actually what this change means is that we're trying to strengthen the local service provision at place for the vast majority of patients who access their care for either outpatients or chemotherapy. We're centralizing in certain locations the more complex inpatients, but that's not all of the inpatients, it's only some of the inpatients. For those patients who absolutely need that aspect of it. So I think that's the one of the big things to highlight. And we know that one of the key determinants to health inequalities is access to care. And actually, if you can improve the access to care, you're likely to improve on health inequalities as well. So actually, I think this proposal makes that better. And then I'm going to bring in the earlier point that Angie made, was that if we did nothing and we stayed as we are, because of the retirement rate we've got, actually our ability to sustain the outpatient care and the chemotherapy at a place level, local to Wakefield or local to Bradford, would be significantly impacted. So therefore, our ability to continue to deliver that in those locations, because we'd lose the workforce, we wouldn't be able to attract the new workforce in, would mean that we're really quite vulnerable in being able to continue to deliver that local chemotherapy and that local outpatient care. I think your point is really valid, though, in terms of being able to see that at a place level. So we've talked about, obviously, across the whole of Wyatt, but what we need to be able to do is demonstrate that for you in terms of what does that mean for the population of Wakefield or Bradford or Calderdale or Leeds. So that was just the additional contribution and clarification I wanted to make there for you.
Okay, thank you. And don't forget Kirklees, and that we're split between two acute trusts.
Yes.
And so our geography goes with Wakefield one way and with Calderdale the other way, which makes it even more complicated in Kirklees. Thank you. Right, Councillor Addy, then Councillor Coates, then Councillor Swift.
Thank you, Chair. I think my fellow councillors have asked most of the questions I was brimming to ask, but I've just got one thing to sort of comment. With the diminishing use of locums that hopefully we can achieve, with the retirements and older people taking reduced hours, the costly experienced people, will this cover the trainees' costs, the new staff that we hopefully will bring on board? But will it also mean we've got a deficit in experience? That's the concern with that.
So I think just to answer that question at kind of a high level is that's the crux of this, is if we don't make a change, if we don't actually change the model that we actually describe at the start of this paper, we will continue to lose expertise from our system. And so the issue is we have to make a change, because we have to recognise the fact that there's that West Yorkshire's system, and I think it was raised earlier in the call, is different to the model put in place elsewhere. But also, as well as the fact is we do find recruitment to the experienced posts more challenging, because we don't have the same concentration of cancer centres, for example, like London does. So again, it's really important to us to both attract, retain and keep talent we do. In terms of the bit about then how we're going to afford it, so for example, we do have, I think Angie raised earlier, we did, this kind of reference figure about 14 substantive oncologist posts, and they're funded establishment posts, but they don't actually have anybody in the post. So some of that cost is being used by locums, but for example, if we can look at, for example, the role of consultant pharmacist, consultant nurse, consultant other non-medical staff, those people can utilise the existing budget, which is set against those particular posts. In terms of how we can make sure that then we don't lose the overall skills gap, and how we make sure the services are more sustainable, that then comes back to the role of the consultant oncologists that we actually have in place, how they operate in teams and how they operate in sectors. So what we've actually been doing as part of the proposal as well is actually having them operate in specific tumour site teams. We've also had some kind of mentoring support, some professional development. And again, what we're trying to do is to actually have some of the oncologists we have act in that operative capacity, developing the capacity of those people around them, being there for escalation support when they need to directly make a decision. And that type of model is actually closer attuned to what happens elsewhere. And we think that's part of the mitigation to the point is what we can't sort out, which is that some of these people will retire in the next few years. And there are plans to increase training places for oncologists nationally. But again, we are in a scenario whereby through unavoidable factors, it's going to be difficult to keep that balance in tune. So what we've been trying to do, Councillor, is to kind of manage as best we can to make sure the fact that we do actually focus on developing the workforce around the consultant oncologists. We have them working together as in teams as opposed to less in silos. And also as well, the fact is we've been trying to make sure is, again, we do take some action on the long-term supply factors as well, which is really important to develop a sustainable service. So does that answer the point you wanted to raise, Councillor Adil?
Well, I was worried about the experience deficit that you're going to have, because I understand that, retiring people are going to be expensive. You can maybe get 2 trainees out of them, but you don't get that experience. I mean, you talk about the centres in London. Is there no national discussion about this and crossing over, maybe transferring, maybe people coming up, then trainees going down to get experience and swapping them for somebody with experience short term, anything, conversations like that to make sure we don't have that experience deficit whilst we're moving forward. Eventually people will be experienced, but
So what we've been trying to do, to be honest, this is what we've been doing directly as a Cancer Alliance. We've been trying to get this particular issue higher on the national radar as kind of a cancer policy priority. So there are differences in how this problem kind of materialises elsewhere and across the country. There are various kind of ways in which you can kind of have skills sharing and knowledge transfer. We also, for example, do have a number of national reference groups, for example, whereby we talk about innovation and best practice in each of these tumour site fields and how they're shared. We also have, for example, kind of a national operative working group with NICE, which we've been supporting, and that's essentially looking at the resource gaps and what are the resource impacts arising from new treatments that are being supported by NICE to deliver care to this population. And again, we're making sure that's been a key consideration, how those drugs are kind of supported, and doing that as on a national basis. So again, some of our work in this space is, again, we have been influencing upwards where we can, as well as resolving the problems locally, recognising that some of the points you raised there, they are genuinely national issues, and so they can't all be resolved simply in a West Yorkshire context, but we have been doing that work too as well. And again, in a subsequent update, we're very happy to give a little bit more detail about that work as well, to give that assurance, Councillor Addy.
Okay, thank you. Councillor Coates.
Hi, yes. Well, I was sorry to hear that there wasn't much consultation with Bradford patients, which is a shame, especially since we've got the Yorkshire Cancer Support Centre literally at the back of the BRI. I do a lot of volunteering work for that area. So really what I want to ask is about the impact on the Bradford patients that have to travel to Leeds, especially for radiotherapy. And for a lot of our patients, it's the travel costs that inhibit, you know, that it's not just travel costs, it's the inconvenience, especially for elderly patients that perhaps need somebody to support them. I just wondered, is there going to be further consultation therefore if we haven't been able to get much input so far?
Yeah, so just to kind of give some further context to the kind of the situation from a Bradford point of view. So again, and I mean, Angie talked about you, so she was right to say, again, the initial ways we tried to reach out to the Bradford City population were not as successful as we wanted to. So again, that's not a case of saying we pitched up, we tried to do something overturned up, therefore job done. We said that wasn't the right thing to do. So we have done a lot more work in terms of reaching out to other groups. In terms of the market research from a Bradford population, which has been assessed in exactly the same way as the Wakefield population, referencing the conversation with Councillor Rhodes, we've spoken to 102 people who are residents of Bradford, and again followed exactly the same independent market research approach as we have done with the Wakefield residents. The other things we have also done as well, in terms of your point about radiotherapy, again, the radiotherapy provision is not directly in scope for what we're doing, but again, it's probably useful to say, as you've raised the point, is that we are trying to make sure as well we have enough linear accelerator capacity, which is deliver radiotherapy capacity for patients in the longer term. We are mindful of the fact is that access to radiotherapy is associated with health inequalities. So there is actually a business case being developed to look at investment in radiotherapy capacity in the future. And again, that does have a significant capital requirements again. So we are looking at, it's not directly a reconfiguration as such, but it's something around invest in the future. And again, that particular business case is looking at a range of different options to deliver that radiotherapy capacity close to home. And one of the options under consideration is a satellite in Bradford, for exactly the reasons you described, which is ultimately that people who live in Bradford can experience significant costs of travel. And whilst it's difficult to make some of the mechanics around radiotherapy and some of the planning services delivered outside of a cancer centre location, there are examples when that model's been well delivered elsewhere. So, for example, in the Wirral and also in East Cheshire. So again, we've learned from those models, and again, that's influenced some of our thoughts there. So the future of this, actually, from a Bradford point of view, is again the potentially, and again, I would stress that that's the business case under consideration. So I don't want to say, you know, there would be that there in the future, but again, we are certainly got that in our mindsets. In terms of the impact on the inpatients, I just wanted to make the point is that the vast majority of the inpatient work, which is in Bradford, will remain in Bradford. So there'll be no excess travel time from this. More outpatient, more chemotherapy work will be delivered in Bradford than is the case now. And for the patients who do travel to Leeds for rarer cancer treatments, which is probably necessary and required for safety and efficacy, that will remain the same as it is now. So when we present that piece of work to you in terms of what do these proposals and the impacts look like by place, the access differential from a Bradford point of view will be positive in the future than is the case now. What I'd find this to say as well, again, looking at the impact of proposals from a Bradford resident's perspective, recognising there's some of the work to analyse results is further required. Again, we also see a good level of support as well amongst the Bradford population from those people we have further spoke to, Councillor Coates.
Yeah, and it was good what you were saying about there are grants for the transport, and there are some facilities for people that are having radiotherapy on the trot. They can stay over, can't they? There's like a mini hotel, I believe. I haven't actually seen it, but I've heard about it. But our issues with the travel and the to Leeds have been ongoing for a long time. I had breast cancer in 1992, and it's been the same ever since about the travelling to Leeds. So I really welcome some satellite provision on the radiotherapy. Anyway, I'm still here to tell the tale. So yeah.
Well done.
Thank you.
Well done.
Thank you. Sajid, did you want to come in on this point? And then the Councillor Swift.
It was on this point, and Councillor Coates, this proposal doesn't change the way that radiotherapy is delivered. Radiotherapy is and will continue to be centrally delivered through the Leeds Cancer Centre. Of course, there will be, I'm sure, in the future, look at overall capacity and volume of radiotherapy, and at what point, if at all, we can look to try and perhaps consider where else there could be radiotherapy provision. But as part of this proposal that we're discussing today, there's no change. So whether you're a Bradford or a Calderdale or a Kirklees resident, you would still continue to go for your radio therapy at Leeds, because that is where we deliver that.
Right. I just wonder with Jason said about satellite, I took it from that.
So
that's wrongly that there might be some provision eventually in Bradford.
So just to be clear, so Sanchez is right. So in terms of the proposals as they are today, from a radiotherapy perspective, unchanged. The point I was making is that we do require additional linear accelerator capacity for the future, because more people have cancer and more people require radiotherapy. What we're looking at is, as opposed to, for example, just directly build that capacity in Leeds, we're looking at what are the range of options to potentially reduce and mitigate health inequalities from a satellite. And the point I was making is one of the options on the table to consider is there an opportunity to look at a satellite in the Bradford locality area? And again, there's been quite a lot of separate work to that. So just to be clear, for the purpose of this, we consider that out of scope because it's a future commission decision, but we just want to give that reassurance that we are really trying to look at this across the piece. And if there is something we can do to make some of this care more accessible to people, recognise the fact is that it's, that the impact of travel here can be significant, and we want to do what we can. We really are trying to help.
I've got constituents and friends that have really struggled when there's been like a 14-day period of radiotherapy, and they're elderly already. The traffic's really bad, parking's really bad. That does impact. They're already stressed because they've got cancer and they're trying to cope with all this stuff. And I know how that really has affected lots of constituents in Bradford.
Yeah, thank you, Councillor Coates.
Thank you. Councillor Swift.
Yeah, I mean, first of all, can I just concur and support Betty's comments for all the reasons, the same reasons that she gave. So without repeating the detail, I think I would support those points. My questions are about a response to some of the things that were said by Mr. Pollock and Mr. Richards. Now, if I understood them correctly, and we all understand that there's a background of increased costs due to more people living longer, etc., and therefore more cancer patients. But if I understood them correctly, they were both saying, I think, that the reconfiguration considered on its own was actually cost saving. Now, that cost saving and also what was said about making the service more sustainable in terms of the staffing shortfall, what we would understand to be, even on the best assumptions, a very substantial staffing shortfall. Are we right in thinking that both the cost saving and the kind of solution, if that's the right word to use for the staffing shortfall, that they both stem from moving work from consultants to other health professionals? Because I wasn't really able to see any aspect of the reconfiguration other than that was either cost saving or alternatively was something that would go to offset staff shortages.
So just on that one, I'm happy to clarify on the part, but I'll bring in Len first, if I may. Len, do you want to come in?
Yeah, so my comments, Councillor Swift, were that we are paying over the odds now because we have to invest in premium time, locums, agency staff, overtime work, and all of those sorts of things to try and maintain a service. In the reconfiguration, there will be more resilience. We will have greater roles for consultant pharmacists, consultant nurses, advanced nurse practitioners. So there is a change in some of that. And my belief is that we can live within the overall envelope. So I wouldn't say it was cost saving, but I wouldn't say it was going to cost us an awful lot more. So my sense of it is that the financial envelope, what we're currently spending now, we can spend better in a more resilient service going forward.
Yeah, and just to further add to what Len said there, Councillor Swift, is so one of the complications of this is the fact you're not planning in a status quo. So in the time been doing this service, obviously the activity of cancer service has grown, the requirements for patients to receive NSO have grown, and we know that's an intractable issue in terms of the prevalence and the further requirements for patients to receive this service. So in reality, the cost of this service will inevitably grow no matter what particular model we actually follow. And that is in some respects a good thing, because it's actually demonstrates the fact that people are living longer and actually requiring and having better experiences of NSO treatment. In terms of the direct impacts of the reconfiguration, though, what we've tried to look at, though, and to be precise, is those opportunities to use existing monies more wisely. And the other point we've actually had a look at as well is the fact is that when you are having the same staff being employed at a premium rate, and even their medical consultants, that's a significant incurred cost. Ultimately, if we can design a more resilient service, we will naturally achieve a cost benefit there, which can be used in terms of the wider redeployment of the service. So I think the potential reason for the kind of the, you know, in terms of the different ways in which what we've said has been interpreted is because ultimately we are not planning in a static scenario. We're planning a scenario whereby more people throughout this period of time require these care and treatments, and indeed we've had to maintain a service for safety and efficacy reasons right the way through the period of redesign.
Okay. All right, Councillor Swift.
Well, given the time, I don't intend to pursue the issue further, but I will simply say that the answers that have just been given didn't satisfy my hope that we could separate out the cost and resource issues of the reconfiguration from those of the overall activity levels. I'll leave it at that, Chair.
Okay, thank you. I think I realise the time. I mean, I have some questions around how easy it is for patients if you're not within a trust's area to get your to have your records across trusts. So for instance, if you're having your chemotherapy in Dewsbury and as a result you're inpatient, if you need inpatient care you go over to CHFT, how easy it is for those records, etc., to be seen by both the CHFT, Dewsbury and your GP. There are a lot of logistical things in there, because when you have something like this, you don't want to have to fight the system or delays in order for the logistics to be worked out, and that to me is important. I would like to see what you've asked people, because I think there's a question, isn't there, as to would you like your chemotherapy locally? Yes, well, I'd like to be in the best place for my chemotherapy, please. You don't necessarily then think, well, if I need inpatient care, am I going to Leeds or am I going to Calderdale or Huddersfield? The key question is what is best for you, and I would like to understand how that has been discussed in your engagements. So what we've talked about is about engaging with hard to reach groups and understanding how you've done that and getting more information on that. I think what we're saying as well is we'd like to understand more about the training and workforce areas, and we'd also like to see the Professor Richards report and your shared engagement outcomes that you've just done over the winter as well. I think that it's important that each place consider this as asked by Wakefield, because there will be different questions and concerns, etc., by each place. I think Leeds were clear that they're fairly content at this moment in time. They don't think it's a substantial, but other places who may have more impacts may wish to discuss those impacts more fully before they actually take any position as to their thoughts. I also think that where you say that the Transformation Board is going to take a decision as to whether they think it is substantial or not, or a variation in service, I just would say that the answer that was given about the engagement has come back positive, so we don't think it is. Many reconfigurations could say that. Well, actual fact, but it is in actual fact because of the changes, it is deemed to be needing some consultation of some description. So I think that alone is not necessarily just a consideration that we would want to see. Obviously, we don't want, none of us want for any delays in cancer care, and we want to see improvements in cancer care across West Yorkshire. But it is for each place to look at the detail for their area now. Okay, all right. Have I covered everything there? Have I got everybody's points? Councillor Rhodes.
Chair, you have indeed covered everybody's points, and can I just reiterate that from today's meeting, obviously I always report back to my scrutiny, as I know other chairs do, and my intention is as soon as possible, please, and I appreciate the workload that people have got. I think it's important that each place has, as soon as possible, the detailed information of what the implications of the reconfigurations are. A timescale as well, I think, is very important for people to know when, if these go ahead. Because I think leading on to the months ahead, I certainly, from Wakefield, and I'll give Len notice now while I have him on camera, I certainly, in terms of Wakefield, for my next meeting, intend to inform my scrutiny committee of the reconfiguration, and indeed letting them know, and I'm sure you all will be doing the same, that we have asked as a collective body of places for the impact and hopefully delivery and outcomes to be with us, because I will be putting it on our work programme. And I think it's important that we get that done, because this is one service, I think, across every place within our West Yorkshire patch that people do have concerns about. And if we can in any way look at these, have the information to allay concerns, as well as bring back feedback to your good selves, I think this gives us an overall opportunity through overview at this particular stage and scrutiny through reconfiguration later on to have that conversation with you all. And I think that's really important, Chair. And thank you for your chairmanship and those who have been present today.
Thank you, Councillor Rhodes. So impact and deliverables to place as well. Okay. Thank you for your time this morning. Thank you. The committee just has one other item, which is the agenda plan 23-24, and we've got on March, we've got workforce prevention and urgent care, and then to be scheduled is the access issues and plans for dental and the ICP strategy, including the 10 ambitions progress. Thank you ever so much, everybody. I realise it's been a long meeting, but I think that discussion has been very, very useful for us all. Thank you for your input today. Thank you. We'll close the meeting.
Bye-bye.
Thank you, Chair.
Thank you. Bye-bye.
Bye-bye.
Thank you, Chair.
Bye-bye.
Bye-bye.